I'm Nicholas Salupo, and this is our case of ocular risks of intermittent hemodialysis. During intermittent hemodialysis, or IHD, patients may experience symptoms related to shifts in systolic blood pressure. Typically, this is due to hypotension, but conversely, there is a well known effect of IHD increasing intracranial pressure. Similarly, there seem to be effects on intraocular pressure as well, but this is less well understood. A transient increase in IOP may cause ocular dialysis disequilibrium, or ODD. This is hypothesized to occur due to rapid shifts in osmolality between the serum and aqueous humor during IHD. This is a case of a 54-year-old female with type 2 diabetes leading to end-stage kidney failure on hemodialysis, which she had started 6 months prior, bilateral proliferative diabetic retinopathy, bilateral neovascular glaucoma, and no light perception vision loss. She was urgently transferred to the ophthalmology clinic for acute onset bilateral eye pain, headache, nausea, and vomiting during her IHD session. She had actually missed her regularly scheduled dialysis session 3 days prior to undergo transscleral cyclophotocoagulation. In the ophthalmology clinic, her IOP was 63 millimeters of mercury in the left eye and 60 millimeters of mercury in the right eye. Normal is 12 to 21 millimeters of mercury. This was consistent with bilateral acute angle closure glaucoma. She was given 500 milligrams of acetazolamide and started on ocular brimonidine, timolol, durvalumide, and latanoprost every 15 minutes, and transferred to the emergency department where she was subsequently admitted. Her hydralazine that she was taking 3 times a day was stopped to limit large systolic blood pressure fluctuations, and she was restarted on her regular thrice weekly IHD schedule with minimal ultrafiltration. Her eye pain has slowly but not completely resolved. Unfortunately, enucleation is the next step in symptom management if medical therapy is unsuccessful. This case is interesting as it shows a ocular dialysis disequilibrium syndrome related to intermittent hemodialysis. The largest meta-analysis of ODD, though, has found no association between IOP and IHD. However, subgroup analysis showed increases in IOP associated with IHD before 1986 and a decrease in IOP associated with IHD after 2005. This is hypothesized to be related to dialysate acetate, which has largely been replaced in favor of bicarbonate. The ODD syndrome is likely due to a desynchronous reduction in osmolality, leading to a hypertonic aqueous humor relative to the blood, producing increased intraocular pressure in individuals with reduced aqueous outflow capacity due to an altered iridiocorneal angle. As dialysis practice patterns have shifted over time, the effect on IOP may be less. However, patients with glaucoma at baseline are still at higher risk. In conclusion, increased IOP can cause severe eye pain, amblyopia, or headaches, leading to significant morbidity for patients with ESKD on thrice-weekly IHD. This effect is less well understood for other dialysis modalities. Pre-existing glaucoma and other aqueous outflow obstructions may increase the risk of ocular dialysis disequilibrium. These syndromes and their symptoms are likely underreported and under-recognized, leading to patients not receiving the ophthalmologic evaluation and treatment necessary to limit disease progression. In cases that are treated medically, acetazolamide can be used. Individualized dialysis prescriptions can minimize symptoms. However, if symptoms are refractory, it may be necessary to pursue enucleation.